Welcome. Thank you for joining us today. I'm Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go through a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has been muted so you can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them throughout the session. Only Blum Center staff and our guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so it is my pleasure to introduce you all. Joining us today, we have Dr. Allison Bryant. Dr. Bryant is a board-certified obstetrician, gynecologist, and maternal fetal medicine subspecialist. She is also an associate professor of obstetrics, gynecology, and reproductive sciences at Harvard Medical School. She is the Associate Chief Health Equity Officer for the Mass General Brigham Health System and is the Dr. Frederick D. Frigoletto Endowed Chair in the Department of Obstetrics and Gynecology at Massachusetts General Hospital. Dr. Bryant evaluates and manages patients contemplating pregnancy and those with high-risk pregnancies. She participates in prenatal diagnosis, sees patients for prenatal care and consultation, and works as part of the inpatient antepartum and labor and delivery teams. She received degrees in biology, public health, and medicine from Harvard University, where she also completed residency training in obstetrics and gynecology and fellowships in maternal fetal medicine in the Commonwealth Fund Harvard University Fellowship in Minority Health Policy. She currently serves as a member of several regional and national women's health and equity improvement efforts and is especially passionate about achieving equity in obstetrical care and outcomes for women of color. Joining us today, we also have Melissa Nelson. Melissa is the director of the Nurse Midwifery Division in the Department of Obstetrics and Gynecology at Massachusetts General Hospital. She received her BA in Liberal Arts from College of the Holy Cross. She received her Bachelor of Science in Nursing and Master of Science in Nursing from the University of Pennsylvania School of Nursing, where she specialized in midwifery and women's health. She has experience in teaching residents, midwifery students, and medical students. Her clinical interests are adolescent pregnancy, centering pregnancy, maternal health inequities, and healthcare leadership. In 2023, she completed the Duke University School of Medicine Advanced Practice Provider Leadership Institute and is an active member of the American College of Nurse Midwives. To join us today to give a talk on understanding your obstetrical care choices. So please join me in welcoming Dr. Bryant and Melissa.
Thank you so much, Amy, for the introduction. Dr. Bryant and I are super excited to just really have a thoughtful conversation with everyone today. So title of our conversation today is Understanding Your Obstetrical Care Choices. Next slide. So we have a few objectives that we wanted to while we're talking about this. So if people have questions they want to throw in the chat, we want this to be as interactive as possible. So we want to identify key factors to consider when choosing an obstetrical care provider, thinking about comparing the different birth settings, explaining the benefits and the considerations for each option, discussing effective communication for working collaboratively with your obstetrical care team, understanding the essential components of our birth preferences, and explaining the importance of support during pregnancy, labor, and the postpartum period. Next slide.
So I will take on this one again. I echo Melissa's thanks for all of you for joining, and also to Amy, appreciate the introduction. And also, it is very hard to say obstetrics and gynecology, so I'm just going to say OB. OBGYN is oftentimes what we call ourselves in our medical specialty. So while not all of you may be thinking about pregnancy care at MGH in specific, we thought we'd just sort of give you a little bit of a rundown of how our practice works. Understanding there's lots of different models for how pregnancy care is delivered, and we'll go into some more of that on some of the later slides. So one thing to say is that OB is relatively new at Mass General Hospital. So the hospital itself opened in 1811, but it wasn't until 1994 that obstetrics or intentional care of pregnant individuals came into play. So there was always gynecology, so taking care of some, pelvic floor disorders or cancers or other things for a very long time at MGH. And then in 1994, folks sort of realized that there was a space and a need in the Boston landscape for adding another maternity hospital. And so that's when MGH opened its doors to caring for pregnant individuals. I had the great fortune of being the second medical school class to rotate through MGH and really have just enjoyed it ever since. So they always say, if you build it, they will come. And that is exactly what happened. So we built a labor and delivery and an OB service at MGH, and people came. And so the service has grown and grown. We've changed our physical footprint a little bit, adding space here and there, but we now do about 3,800 deliveries at MGH per year. And our team is incredibly important to us. You'll hear us say team over and over again as we sort of talk to you all, but our team includes a number of different kinds of care providers. So, in terms of who provides care during pregnancy or before or after pregnancy, that includes our certified nurse midwives that Melissa will talk a little bit more about. I will talk a little bit more about the role of the OBGYN specialists, so physicians who specialize in obstetrics and gynecology, and then other physicians like myself who specialize in what's called maternal fetal medicine. And then our team is really much, much larger than that. So I've added here registered nurses and lactation consultants, but really the teams both in the hospital and then in our office side, in our ultrasound suites is much, much larger than that. And so some of you may have heard in the news or in other places that Mass General Brigham, which is our large healthcare center that has actually 8 labor and deliveries within it. Within Mass General Brigham, the two big, what we call academic medical centers, now the academic departments have merged. And so we at Mass General Hospital are now in an integrated Mass General Brigham service with the Brigham and Women's Hospital, or it's really an academic department. But the clinical services right now, where you get your OB care, really remains separated by campus. So our patients are for the most part, Mass General OB patients, but lots of collaboration and thought between the sites. And then also really importantly, both to our health system and then to our hospital, is that we want to make care convenient and safe and level appropriate for all of our patients. And so we offer lots of options for outpatient care. So office-based visits, ultrasounds, labs at many different sites in the communities that we serve. So hopefully not too many of our people have to travel too far to get to see us, although the births only happen on labor and delivery at our hospital in Boston. So click to the next slide. Melissa, will I pass it back to you? You don't want me to start this slide or do you want to get started?
I can get started. So we wanted to just really be able to highlight a little bit of the different provider teams, right? So I think when people think of, okay, I'm pregnant, who do I go see? Depending on your background, your family, what you know, you might be like, I'm going to go see a doctor, or you might be like, I'm going to go see a midwife, or you're like, I want to see an MFM. So I think it's important when you're thinking about really understanding your obstetrical care choices is like, what are the different provider types, right? So we have certified nurse midwives, we have OBGYN specialists, we have maternal fetal medicine subspecialists. So I'm going to focus more on the certified nurse midwives, and then Allison will talk about OBGYNs and the difference between them and MFMs. One of the things that I think it's important is that the most important thing to think about is collaboration, right? You want to ensure that your provider team is collaborative in nature and supportive, right? So for certified nurse midwives, we are advanced practice nurses. And for all intents and purposes for this presentation, I'm just specifically speaking about certified nurse midwives. So we all have our nursing degree, and then we all also all have our masters, where we specialize in midwifery. And a lot of the things is that birth is normal till it's not normal. So for us, this is a very normal physiologic event. Okay, midwives can take care of a variety of different patients. We love to take care of our low risk patients. However, we do have training with the collaboration of some of our OBGYNs and MFMs to be able to care for patients that might be medium to moderate risk factors. Midwives can practice in any location. So we can practice in hospitals, we can practice in birth centers, we can practice at home. It really depends on your state regulations. And I think one of the things that people forget about midwives is that we just not only do pregnancy care, but we do all types of care, right? So we are all about reproductive health care access. So we have midwives, just nationally, midwives can provide benign GYN care. They can do menopausal care. We can do your pap smears, STDs, family planning. So midwives can provide a wide range of resources as well as services to our patients. So for us, we can see people when you first got your period. We can take care of teenagers all the way until women are a little bit on the a little bit more on the older end, just kind of depends. But for this intensive purposes, midwives in the obstetrical context, yes, we care for patients who are actively, they're pregnant, they are desiring a care that is really normal, and think about the physiological aspect and think about the holistic aspect of that person. I think when we, like I said, when we view birth is normal till it is not normal. We are trained. We are trained in recognizing emergencies. We are trained in handling a variety of different emergencies. And when people get cared for by the midwives, they think like, oh, I'm only going to see you for prenatal visits, or I only see you postpartum. But midwives can deliver patients. So there is times when I tell my own patients that you may go the whole entire time and not have to see a physician, and that's a good thing, just because that means your pregnancy was low risk and that there was no issues with that. And sometimes we might need to consult with the physician teams, whether it is something going on with your ultrasound, or maybe it's something going on medically, or even maybe something going on with the baby. So that's where I talk about the importance of that collaborative nature, but recognize that certified nurse midwives are covered by insurance. Recognize that we can take care of people throughout their pregnancies. Some practices can be more collaborative in nature. Some practices can be a little bit more like you see the midwives, and there's anything, then you go see the doctor. So it just really depends on what's going on and what's actually within that institution. Allison, I'll have you chime in for the OBGYN and the MFM subspecialist portion.
Sure thing. So I will chat about the other two that you see on the screen, which are the sort of physician side of obstetric care. And really, as Melissa said, for us at MGH, we really do have this very collaborative, sort of interwoven pattern of care, which I personally love. But in terms of who our OBGYNs are and our MFMs, they are physicians. And so what that means is that they've completed some sort of undergraduate degree in any field. And then they've gone to an accredited medical school, usually in the United States from our practices here. Sometimes folks have gone to have their medical training and their education in other countries. In the United States, it's a 4-year training where you get a broad sort of learning of experience about sort of basics and classroom learning. And then you spend a lot of time immersed in hospitals, offices, helping take care of patients and learning the care of patients. When you graduate from medical school, you are not specialized in any one area. And most individuals who finish medical school in the United States then pursue what's called a residency training. So you may have heard of residency or internship. Internship is the first year of a residency. And that number of years varies by specialty. So for individuals who are interested in becoming an OBGYN, which is really the sort of specialty that specializes in women's health or reproductive health care, caring for pregnant individuals, caring for reproductive health across the entirety of the lifespan, that is OBGYN. And OBGYN is a 4-year residency. So our residents spend time learning the intricacies of our specialty. When folks have graduated from their residency, they are fully trained obstetricians and gynecologists and oftentimes go into practice in various settings. So, whether that is in a health center or a community hospital or in private practice or an academic medical center, lots of options for care for professions for individuals. Um, for us, again, speaking about the pregnant individual, OBGYNs oftentimes see people for what we call preconception care, so prior to a pregnancy, to help people and couples and families think about family planning and family building and entering a pregnancy as healthy as you possibly can. They also provide prenatal care, so care during the course of a pregnancy up until the birth. In our hospital, they also work on labor and delivery. So they take shifts on labor and delivery where they spend time evaluating people in labor or doing vaginal births, participating in cesarean deliveries or other operations, and then see people postpartum after they've delivered in the hospital or back in their offices. One lovely thing about obstetrician gynecologists is that they also see patients really, as Melissa described, across the lifespan. So typically beginning in young adulthood, although some are specialists in pediatric and adolescent, say gynecology or providing obstetric care, prior to the age of 18, for example. But oftentimes our OBGYNs will see people before pregnancy for gynecologic, family planning, birth control, problem visits. They may see them throughout a pregnancy. They may see them through their delivery and into the postpartum, the after pregnancy period of time, and then continue seeing them for their preventive care, for their mammograms, for sending them for colon cancer screening, all throughout the lifespan, and then into perimenopause and menopause and older age. So, really, just a great experience of longitudinal care for many of our OBGYNs. Um, in terms of our maternal fetal medicine subspecialists, those folks, like myself and some of our partners, really hone in on a specialty that really involves high risk pregnancy. And so, whether that's high risk for the pregnant individual or high risk for the fetus, risk of complications, that's the additional training that maternal fetal medicine subspecialists have had. So, we, similar to OBGYNs, went to an undergraduate degree, had 4 years of medical school, 4 years of residency, and then here in the United States, 3 years of additional training in something called a fellowship to really learn additionally more skills in this maternal fetal medicine space. And so, somewhat unlike OBGYNs, we don't oftentimes see people over the entirety of their lifespan. We see them specific to pregnancy. So, whether that's before pregnancy to help with planning and counseling about a pregnancy that could be high risk if we have a pregnancy, the pregnancy care, many of us provide prenatal care in the offices. Many of us also work on labor and delivery, doing deliveries, doing C-sections, seeing people postpartum after the birth has happened. But typically, for many of us at MFMs, that's the time after that postpartum visit that we may say goodbye to our patients unless they come back to us for a next pregnancy, because we don't typically provide all of the gynecologic care or menopausal care that the OBGYNs or the certified nurse midwives do. So MFMs do those things that I spoke about. The one other thing that we oftentimes do is engage in prenatal diagnosis. So things like ultrasounds. So if you have ultrasounds during your pregnancy, oftentimes those are done by high-risk pregnancy specialists who will care for you and tell you what they're finding on ultrasound, as well as consultations. So that's kind of the breadth of the specialties that we have at MGH and a little bit of how they work. So maybe we'll go to the next slide.
So now one of the things that is important is that you understand the specialties, right? And you're understanding all the different aspects of it, but you also want to think about your birth setting. So, one thing that I think is important is really defining, okay, where are you in the risk factors, right? I think sometimes people are like, okay, I'm having a baby at 38. That makes me high risk. And yes, you are considered advanced for maternal age. However, as a midwife, I can see somebody who's pregnant at 38, 39. So I think sometimes you really want to identify, and that's something that you really want to think about is like, what are your risk factors and who really should be the most appropriate person? I think as people are getting pregnant later on in life, and Allison, correct me if I'm wrong, I feel like I see a lot more patients who are 35, 36 having their first baby. And, I think we have guidelines and things like that where we all practice that you're able to still get that great collaborative care and still receive the ultrasounds, any special things that you would necessarily need. But I think it's important to understand those provider types, especially when it comes to the various settings. So birth settings are dependent on a variety of different things, right? So there are people who probably have heard people who have home births, people who have birth center births, and people who have hospital births. So what I think it's important when you're thinking about birth settings, it's really depending on a variety of different things, right? What is your medical history? What are your risk factors, right? What about access? So sometimes in some cases, if you're in a state of California, they have a lot more access to birth centers, a lot more access to home births in comparison to some other states, right? You want to think about insurance, right? So sometimes in some of these places, your insurance can cover birth center birth and could potentially cover a home birth. Definitely covers a hospital birth, but also that might impact your ability of deciding where do you want to go, because if your insurance doesn't necessarily cover a home birth or a birth center, right, that cost is going to be a factor in terms of deciding exactly where you want to do in terms of birth setting, right? I think one of the other things to really think about is your personal experience, your familial experience. So what do you understand about birth? What has been your own aspect of birth or others that are around you? So I think it's important to really think about, people are always saying, well, I want to deliver here and I want to deliver there. But I think it's important to really think about, what is that setting that you want to be in, right? So what does that team look like if you deliver at home versus a birth center versus a hospital? So we'll talk a little bit about some of the questions that you really want to ask if you're going into each individual settings. As a midwife, we have midwives that do home births, right? And I do think sometimes some birth settings are not for everybody, okay? I think like we talked about those risk factors, your medical history. However, home births can be an option for people. I think it's really about finding the right provider and really asking some of the questions that I'll bring up after Allison does her portion of what are some of the things that you really want to really understand when you're going to deliver in any of these birth settings. So home births are it's with a midwife, it's usually coming with a team. So you usually will have two midwives. You'll have some birth assistants helping you as well too. This is in the comfort of your own home. They are actually coming to you, right? So those that are experiencing a home birth, you're thinking about, okay, the benefits could be what is helpful, what is going to work for you and your family, what is some of your beliefs and your views. So some individuals are able to deliver at home, they want to deliver at home. There are some people who are like, I want a little bit of both worlds where I don't want to be in my home, but I don't necessarily want to be in the hospital. And that's where birth centers come into play. Within the last few years, there's been a lot of attention about maternal mortality and just our maternal healthcare system, and really thinking about the fact that in many other places, they have a lot more integration of going from home to a birth center to a hospital or vice versa. So again, being to know, are you eligible for a birth center really depends on where you live. Currently in the state of Massachusetts, the only birth center we have is Seven Sisters, and that's up in Western Mass. But we don't have one in the Boston area. So if you wanted a birth center birth, you could want one. However, there's not that option because we don't necessarily have one. So it's really important to understand what are the options that you have. And a lot of the times with home and birth centers, more midwives are involved in those in comparison to hospital births where there are midwives, and at MGH, the midwives at MGH all deliver in the hospital. However, I think it's important to understand what care providers you're going to get, depending on where you are desiring to live. And I know, there are many people who are like, well, the safest place is to be in the hospital. And that can be true. However, I do think that it all depends on the person. It all depends on your values. It depends on what's going on with you medically and what's happening. And I'll give a little bit of time for Allison to talk about hospital stuff, and then I'll go back and talk about what are the questions you should be asking when deciding on what birth setting you'd like to be in.
Great. Thanks, Melissa. So, yeah, happy to talk a little bit about birth in a hospital, which I think many people have some familiarity with, but there's probably also lots of good questions. And so, definitely put questions into the chat. So, hospital setups sort of definitely vary by place and by state and by, organization, whether you're in a big hospital or a small hospital. So, in terms of delivery in a hospital for us at MGH, for example, our labor and delivery is a single unit within the hospital. It's a locked unit, which I think is actually important to think about, right? We want to make sure that particularly our babies who can't really sort of speak for themselves are safe from harm. And so we have a locked unit that really restricts who can come in and who can come out. And so knowing who's in our unit at all times. There's like a mini emergency room in our labor and delivery. And I think that that's important too, is that we consider all of the folks who work on labor and delivery to be expert in pregnancy care. And so all our colleagues in the emergency department are fantastic, and there are lots of times where the emergency room is the right place for someone who is seeking care, figuring out what's going on. If something is pregnancy related, then oftentimes you'd come up to what we call our triage, which is our mini emergency room on labor and delivery. We also have on our labor and delivery what's called LDRs. And so that's labor, delivery, and postpartum rooms. And so those are rooms where individuals come in, usually when they are in the midst of labor or undergoing an induction of labor, in spontaneous labor, but they are rooms where people stay where they experience labor and then also have vaginal births in those rooms. In some hospitals, and sort of like maybe even in the old days, you might see scenes where people had labor and they get rushed off to the delivery room. I think those are fewer and further between, but there probably are some settings around the country where that's still the case. But for us, we try to maintain as much as sort of a like home-like environment in the room as much as we can, but that's also where your delivery occurs if you're having a vaginal birth for most individuals. And then we also have operating rooms. So we know that, I think one thing to stay out loud is that for most people for whom it is an appropriate thing, we are wishing for a vaginal birth for many of our individuals, again, engaging in some shared decision making with folks around what we call mode of delivery. But we certainly know that not everybody who intends a vaginal birth will actually end up with a vaginal birth. So there are some medical reasons why a cesarean delivery may be needed. And so we on our labor and delivery floor have a couple of operating rooms where those C-sections or other procedures can be performed. There are some hospitals, smaller hospitals, or just other setups where those operating rooms are shared with the rest of the hospital. So you might go down and have your C-section next to someone who's having their gallbladder out, which is totally fine, and they have figured out those systems. But for us, our operating rooms are contained in our labor and delivery unit. And then for us, the kind of room that is separated is called postpartum. So for us, our postpartum rooms where people stay for 1, 2, 3 nights or sometimes more after their births are downstairs one floor from our labor and delivery. And so that again is sort of like what kind of home-like environment, as much as we can make a hospital environment a little bit like home, where families sort of stay to get the medical care that they need after a birth has happened. We also have what's called antepartum rooms. So if someone has a reason to be in the hospital during their pregnancy but are not delivering, there are some rooms that they might be accommodated there too. In some other hospital settings, they have what's called LDRPs, so where you labor, deliver, recover, and then also have your postpartum stay all in the same room. So there's lots of different setups in the hospital. In the hospital, in terms of the teams, all of those care providers that we mentioned before work on labor and delivery, caring for individuals really in collaborative ways. We also have registered nurses who take care of patients at the bedside. We have lactation consultants. We have folks from nutrition services and all the other supports that are needed during a hospital stay. So that's a little bit about sort of the physical setup of our hospital environment, but happy to answer sort of other questions. I think the one other group that I will say that's really important is the pediatricians or the individuals who care for neonates or newborns after they are born. So at a big academic hospital like us, where we deliver patients who, you know, are delivering very early because something has happened in the pregnancy that need an early delivery. We also have a NICU, a neonatal intensive care unit, where those smallest babies or babies that have very high need may be. And then the rest of the babies are cared for by our excellent team of newborn pediatricians who then pass on that information when everyone goes home to say, here's what this baby will need in the ambulatory or the outpatient space. So that's a little bit about our hospital environment. So maybe we'll go to the next slide and people can populate the chat with more questions about the environment.
Actually, Allison, before we go to the next slide, I just want to go back to the birth setting slide, because I think one of the things I want people to really think about is like, what does your team look like? What is their plan if there's an emergency, right? Who's involved in your care? So actually thinking about, okay, if you are in an academic medical center versus a non-academic medical center, who's involved? Will you have learners? Will you have residents? How does the nursing staff support laboring patients? What options are provided for you for pain relief? Do they support a trial of labor after C-section? So there are people who've had a C-section, okay, and they want to attempt for a vaginal birth. Does that place actually support it? And what is their philosophy of care? So when you're thinking about a birth setting, you want to think about some of these questions. And also, like Allison said, not everybody is going to have a vaginal birth. So in terms of like, if you are a first-time pregnant person, what is your chance of having a vaginal delivery successfully? We call this the NTSV rate, which is Nella-Paris term singleton vertex. So just lots of words. However, it's saying that what is the percentage or what is the rate for a first-time birthing person to have a vaginal delivery? You want settings that actually you want it to be less than 20%, meaning that you essentially would have, there would be a 20% chance that you would have a C-section being a first-time birthing person. So I think these are some questions when you're thinking about that birth setting, whatever birth setting that you're in, right? About asking for these things, especially as you're trying to think about where do I want to live? And I mean, where do I want to birth as well too? Next slide. So one of the things I wanted to also talk about is everyone talks a lot about the pregnancy, the labor, but I think one of the things that's important is that what does that support look like, right? So when you're thinking about support during pregnancy, labor and delivery, and postpartum, you need as much support as you can. And that support can happen from your village. That also support can actually come from the place that you're actually giving birth. So thinking about doulas, right? So understanding the importance of doulas. So doulas are labor support individuals. They're not medical professionals, but they provide labor support to pregnant people during their pregnancy, during labor and delivery, and postpartum. So there are some doulas that are mostly postpartum doulas. So they provide that support. They come, they help you. They can be trained in terms of breastfeeding and other resources. And then you have individuals who will support you during labor. Because one of the biggest things, depending on where you deliver, if you are in a hospital setting, we work in shifts. So although you may have that one provider that you're seeing, it may not be that provider that's actually delivering you, right? Whereas maybe at a home birth or in a birth center, that's a little different because the patient caseload is a little bit smaller and it's a little bit smaller of a group. You may actually have the person, it's more likely for you to have the person that's been taking care of you deliver you just because of how that model is typically set up. So doulas are super helpful because they are helping the birthing person and their family or their partner, whoever they deem as their support person, and helping them navigate all of this, right? Because not everyone's experiencing this. So, me working in the hospital settings, we are very supportive and we embrace doulas. We work as a team, especially because doulas research has shown that doulas really help people or help individuals get closer to their goals when it comes to their birth, more likely to have a vaginal delivery, more likely to be satisfied with their care. Okay. When you think about here, I couldn't find something that said birth preferences. Plan is super restrictive. So I say birth preferences. So AKA your birth well wishes. What should be on it, right? I think these are conversations, especially because it's kind of like your wish list. So really thinking about, especially if you're going to have different individuals being a part of your care, What are your goals? What are your desires? How best do you communicate? One thing I always say about birth preferences is that it should be flexible. We should use it as a communication tool. And I think it's important just because it can really help outline and kind of help set with some expectations, but knowing that there can be some aspect of flexibility with it. Um, um, Allison, I don't know if you have any insight about the doula stuff, because I know you're also really instrumental in the Birth Partners program as well at MGA. So I don't know if you had any additional insight before I talk about the other two.
Yeah, no, thanks for the turn. We are really supportive of doulas, and sort of as Melissa said, they really are an evidence-based way. We do a lot of thinking about like, what does the science say? And so the science definitely says that having doula or professional support will have lots of benefits. And so we really encourage them for individuals. We know that some insurances are now covering them more broadly. We do have some specific programming at our hospitals that allows some access for some folks to doulas. So really happy to talk more about that, but really are very pro doula around our spot.
Mm-hmm, mm-hmm. And in addition to that, I think infant feeding support. So I think one of the things that I think it's important is that you want your baby to be fed. And however that feeding is, whether it is breastfeeding, formula feeding, it's really a personalized, individualized choice. But being able to get support when it comes to how you're deciding to feed your child, because it can be emotionally tough, especially because the fact that if it doesn't go necessarily the way that you'd want to go, or you need additional support. So really thinking about what does that look like, that education, okay? And then you want to think about your postpartum support. Who's your village? Who do you know is actually going to be supporting you? What are your triggers? Are there any cultural and religious considerations to think about that will help you during that time? I think people think postpartum is like really the first 6 weeks, where it's really honestly the rest of your life, but especially those first 12 months is super important because there's lots of transitions that are happening, not only for yourself as you are becoming a parent, but also as you're navigating the joys and sometimes the difficulties of parenting. You want to make sure, what other resources does your place provide you in terms of postpartum support? Or do they offer different services? Do they have support groups? And really thinking about that mental health aspect too. There's lots of hormones, lots of different transitions. So when I always say, people are like, oh, we have to plan for the baby and the baby shower, I always say you should also plan for the postpartum period as well. Who's going to be with you? Who's going to be with you those first couple of weeks? How do people want to organize their leave? So I think when you think about support, it's not just what's happening on labor and delivery. It's saying, what is the support you need during the pregnancy, when labor and birth is happening, in addition to what support are you going to need during that postpartum period, because it's a lot. And one thing, especially because if you have a birth that does not go as planned, or you yourself have complications, you are now trying to heal yourself while taking care of a newborn as well too. Next slide. So one of the things is really talking about self-advocacy during your pregnancy, labor and delivery, and postpartum. So I think when you think about how can I advocate, how can I make sure my voice is being heard, right? I think childbirth education classes, I think that's important. Education is power. So really understanding, what is the process? What does it look like? What's going on? And kind of going from there, right? Understanding your own health. So I think pregnancy is really interesting. For some individuals, that's their first time really accessing healthcare. So for them, when they're feeling like they're accessing, it's like, what's going on? Do you have underlying diabetes or hypertension? Do you have underlying thyroid issues? Okay. Really trying to understand that, because that's going to shape how your pregnancy is going to continue and may impact depending on like if it's controlled versus not controlled. We talk about birth location and understanding your obstetrical providers. And also your hospitals. Not all hospitals are created equal, right? So really thinking about, as Dr. Bryant had talked about, we have the level NICU that we have, right? If you go in some places, they will have a NICU, but it may not be a high level NICU. So that's also something to think about. Like, hey, if my baby's born premature, if I deliver at this hospital, I might have to get separated from my baby, versus if I deliver at this hospital, they have a NICU that they can see a baby from as early as 23 weeks and up. Pain management. I think pain is something that can be different for different people. So really understanding what pain management options am I able to have during that particular time, and really understanding the statistics, right? I think what people don't realize is that when you're going to these practices, you have the right to be interviewing and saying, hey, what is your C-section rate for a first-time pregnant person? How many providers are on? Do you have a laborist model? Do you have midwives? Like, who are the people that's actually going to be taking care of me? You really want to kind of understand that, because I think if you're somebody who's like, I want the provider that took care of me to deliver me, then you really have to think about, okay, what practice do you really want to go to, right? Because especially in a lot of these larger academic practices, we do continuity in the office, meaning you'll see that same provider for the most part in the office, but on labor floor, we do have shifts, and your provider most likely won't be the one that's going to deliver you. So really understanding and asking, what do you guys believe about doulas? How do you guys incorporate someone if they want to go unmedicated? Really asking those questions. How do your nurses support you, whether they're in the office or they're on labor floor too? I'll let
Sorry,
Allison,
yes.
yeah,
So I
talk
was trying
about
to
the
unmute.
values. No, you're
Yes,
fine.
I
You're
was
fine.
struggling. Hi, everybody. So I'm just going to talk about the other two columns. So sort of thinking about how do you match up, your own values with finding sort of a good spot for your healthcare. And that I think is just really critically important. I think oftentimes, we ask people kind of what are their own goals. We hear healthy mom, healthy baby. And so we certainly share that. Those are squad goals to be sure. And yet that feels like the minimum of what we should supply to you all, right? We should be making sure that you and your baby are safe. And yet we really do want to make sure that individuals have their values and their goals and their preferences sort of heard and honored. And so I think as you think about care practices, that idea of, am I going to see the same provider? Is that really important to me because I have very specific things that are my ultimate goals for a pregnancy or a pregnancy and beyond? That I want to match up with an individual provider? Do I want to try to like meet as many people as I can who might be participating in my birth? All of those things are really important. I think the concepts of shared decision making and informed consent are also really important. And you want to make sure that the provider that you are seeing really sort of like is a good thought partner for you. Is that shared decision making is a little bit hard. It's a little bit of a fuzzy concept, but we sort of, we have this pendulum in medicine and midwifery that has swung back and forth. Although I would say that the midwives have done it better than the doctors of not being heavy handed, right? Like I cannot tell you what to do with your body. I can give you my best estimates of sort of risks and benefits, and then people need to make their own choices. And so there's some sharing of information that happens in sort of our encounters. And I think that some providers are better or worse than that than others. And sometimes you get a vibe from that from meeting folks. And I also think it's not the most comfortable concept for all individuals. And so you and your family kind of know the style that sort of will make you the most comfortable. And so I think that that's really important to try to seek out a match there as best as you can. And then informed consent for us really is like, again, sort of one of those baseline floor concept is that we should never be doing anything to you, to your body that you do not understand the risk, the benefits, the consequences of, and give us that implicit consent. And so that is sometimes like most clear, like if we're doing a surgery or something that's a procedure, but really for all of the things that we do, when we do exams, when we, draw your blood, all of those things are actually somewhat implied, and you just want to make sure that you are feeling heard and that there can be an exchange of information. In terms of resources, we've gone over some of these things, but we know that some practices, some care settings are more resourced to offer some of these things than are others. But we also know that some communities oftentimes have these things available. And so just knowing the full landscape of where you might get your care and where you might be bringing a baby back to is incredibly important. So if you value a doula, are you in a spot where there's lots of doulas and you have choices and you could interview different doulas? What is the culture of the place that you'll deliver when it comes to those professional support people? I think perinatal mental health is incredibly important. So, whether you have a history of mental health issues like anxiety or depression or other things that put you at greater risk during the pregnancy or after the end of the pregnancy for having sort of an increase in those symptoms, everybody, frankly, is at risk for perinatal mental health issues. And so you want to make sure that you are in a care setting that sort of understands that, values that, and has some resources to help should they sort of occur. And then again, many of our communities are so well set up for some of this. Is just, are there community-based organizations? Are there support groups that are run by faith-based organizations that you might sort of leverage or take advantage of? Knowing your full landscape is really kind of important. And oftentimes, just like hearing, I tell people, sometimes we tell people at the third trimester, like, you have to fill out this form that says where you're going to bring the baby for the pediatrician. And people ask me, where should I go? Like, where, should I bring my baby to MGH? Because suppose the baby has to get admitted to the hospital. And what I say is, like, the likelihood of that is really, really low. Like, even though it feels a little stalkerish, go to the playground and go ask people who are there, where in this community do you guys go for your pediatric or family medicine care? There's some great resources, I think, out in the community that it's oftentimes helpful to rely on. Um, I will have the little asterisk you can see on social media and the Dr. Google and ChatGPT, because I think that we have to acknowledge in this day and age that these are frankly resources that people are turning to. So these are ubiquitous, they're in your hand, they're in, in your phones, you are hearing things, people are sending you Instagram posts around pregnancy. And so I just tell people they have an important role to play, but I would say to use them very carefully. Oftentimes, especially when things, arise that are a little bit different than the normal, or something that someone's found on your ultrasound that's a little bit different. If you go down the rabbit hole of the Dr. Google or the Chat GPT, what comes back at you oftentimes is super overwhelming and not filled with all the context that sometimes your healthcare provider, your doula, others in your circle can kind of provide. So a little bit of caution and just remembering that people put into social media oftentimes the untoward or the unexpected things that have happened. When you have X thing and everything else has turned out to be normal, those folks oftentimes don't put things into that algorithm. And so what comes back at you sometimes is a little bit of a biased sample. So recognizing that those things are important, but they just need to be used with caution. And then lastly, so incredibly important is just your village. Your village is probably your greatest resource. I always sort of harken back to sort of before the pandemic. We were just getting to this spot where we're telling people that the ways to kind of somewhat avoid or mitigate things that might happen that, we'd like to avoid is bring in your people, like bring the people who, know what your preferences are, can help you to advocate. And then the pandemic came and sort of shut down the world in some ways. And we had people who were birthing in ways that sometimes they were frankly alone or just had one or maybe two support people. And so I think we're getting back to being able to sort of really welcome the village in, but I just think it's so important to talk to your mom if that's the important person for you. Talk to your mother-in-law, your grandma, like your grandpa, all of the people that are important to you to make decisions, is rely on those folks. So I think that that might be the end of our prepared slides. So I think that the next is just tackling any questions that you might have. And I know that there have been some that have popped into the chat.
Yeah.
Yeah, go ahead, Melissa.
No, I said there's one question about, can you talk a little bit about spotting during pregnancy, most specific around 12 weeks, what is normal, what is not?
Oh, I'm happy to take some of that. I know that we've responded a little bit privately. So one is just to say that we can't unfortunately offer specific medical advice because we don't know your personal circumstances and don't really want to give information without knowing that whole context. I would say that bleeding in pregnancy, I often tell people, is common but not entirely normal. So it doesn't necessarily mean that there is something wrong, but oftentimes really is a reason to sort of talk to your healthcare provider who will know a bigger part of your picture. But bleeding can sometimes be, I think we're talking about vaginal bleeding, can be sometimes from the cervix. So, right, so something might be a little bit like an abrasion or a bruise that's coming out. Sometimes it can be from higher up inside the uterus. Sometimes that puts you at higher risk for other complications, but oftentimes it's a blip in the road and we never hear from it again. So I would say it's common, but not stone cold normal. And another question that I saw was just about maternal fetal medicine subspecialists and whether they see only high risk individuals. And I would say that for the most part, the answer is yes, MFMs typically are reserved for individuals who really do have higher risk of having complications. And so oftentimes, if that is not your personal circumstance, seeing an obstetrician gynecologist or a midwife is really the right answer. I will say the one kind of exception in my own personal practice is that sometimes people are at high risk because they have one fetus that's at risk for something. And then in their next pregnancy, there's nothing else going on, but we have already established a relationship and I am your doctor. So oftentimes you can come back to see your MFM, even if that pregnancy is not at high risk, but usually you get in the door because there's something going on that we think that's a need.
There any other questions that folks have that they want to hop into the chat?
I don't see any more coming through.
No, I don't. I think one big thing just to think about as you're trying to figure out where is it that you want to go or who is it that you want to see. I think it's just really understanding what is important to you, and what's going on. I think one of the things that's important is that, as a midwife, I want to be able to take care of everybody, but also recognizing that there are some patients that I'm like, I think you'd be best served seeing one of the OBGYNs or even seeing one of the maternal fetal medicine doctors. And I think the same could be said vice versa, as well too. So, I think really just kind of thinking about it's a journey, right? And you are just a part of this journey and you should really be at the center of all of this. So going to a place where you feel heard, listened to, respected, really being able to understand, what are the stats, and everything like that. I think there's a question is mental health considered for an MFM referral?
Yeah, it's a great question. So I think that what we think of is, again, anything that puts pregnancy at higher risk for complications. And so certainly some mental health conditions would fit into that category. I think that said, individuals who have mental health issues may also very, very well be cared for, and sometimes maybe even better by some of our midwives and our OBGYN specialists. I think the other thing to say is that we collaborate with one another, but we also collaborate with other specialties. And so, particularly in the area of perinatal mental health, oftentimes we sort of really want to make sure that folks are plugged into individuals who take care of mental health diseases who feel comfortable in pregnancy. And we can make those referrals within our healthcare organization or collaborate with community providers. But that's a really important one, particularly postpartum, because we want to make sure that people are really well supported during that time. Yes.
So I don't see any additional questions. Thank you so much, Alice and Melissa, for your time tonight. Before we end today's session, do you have any final thoughts you'd like to share with the audience?
I would say just to thank you all for attending and for your interest. I'd say spread the word, tell your friends, pass the recording on. I just think collaboration and team-based care is the name of the game, and also just sort of personal values and matching that up. So really excited to be here and so glad for the introduction.
And I would say similar as I talked about before, I think just finding people in a place that you feel heard, listened to, and just knowing that um, it's not just a one-stop shop. So, I'm always going to advocate that everyone should come see the midwives. However, you definitely should go see a provider and be in a system, again, like you feel heard, you feel listened to, and that will take your needs as best too.
I will also echo that I would say everyone should just go to the midwife. I will say that one of my best days on labor and delivery was having delivered a patient and gone downstairs, and she was on the phone and she was like, "Hold up, my midwife is here," and I was like, "I win." So I just any channeling of the midwifery model of care that I can do gives me great joy. So
Thank you both. And for everyone joining tonight's session, thank you so much. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. I also included that link in the chat.
Thank you. Have a good
everyone.
day, everybody.
Thank
Good
you,
night.
everyone. Take care.
Bye.